Good afternoon, everyone. It's my absolute pleasure to welcome you to this session on degenerative lumbar disease as part of BritSpine. My name's Tony Bateman. I'm a surgeon from Derby, and I've got Siobhan Steins here helping me to moderate the session and bring some intelligence and intellect to the panel here. And we've got some wonderful speakers lined up. So without further ado, we'll hand over to our first speaker, Mustafa Besher, to give us his talk.
Hello, everyone. Try and bear with me as you fight the food coma post-lunch. My name is Mustafa. I'm one of the orthopedic registrars from Aberdeen, and I've come to chat to you about my project for patient prioritization for lumbar decompression according to the preoperative patient-reported outcome measures. Oh, there we are. No conflicts of interest, is it clear? And so just some broad context. So there are national and regional targets for outpatient waiting times for referral, where national targets are 18 weeks from referral to treatment, and then some regional targets for Scotland, where I'm based, is that we have MSK, so musculoskeletal hubs, which aim to see patients within 4 weeks of referral. So we're not doing too fantastically at meeting those targets. So the wait to see a spinal surgeon in NHS Grampian is between 21 to 34 weeks for a routine referral. And the kind of outstanding list of patients to be seen at an MSK hub is standing at 76,000, and only about half of those are being seen within the 4-week kind of target that's being set. So any sort of tweaks or improvements we can make to the outpatient flow of who's being referred to see a spinal surgeon will help us meet these targets. So my project looked to investigate or aim to investigate the relationship between preoperative patient-reported outcome measures and the post-op difference at 1 year for single-level lumbar decompression surgery, with the aim of this insight helping to identify patients most and least likely to benefit from surgery, as well as better inform and counsel patients. So I collected data between 2018 and 2022 at a single centre, which is the elective hospital in Aberdeen, Wood End General, on all spinal decompression surgery that was being taken place. We excluded multi-level decompressions, non-lumbar decompressions, and any revision surgeries. All patients were given preoperative and 1-year post-operative PROM questionnaires in the form of Oswestry Disability Index, ODI, and EQ-VAS questionnaires. And I did linear regression using R for my analysis. So just to help interpret the graphs, quick refresher. So both these scores are from 0 to 100, but for ODI, obviously 0 represents a healthy individual, whereas EQ-VAS 100% represents a healthy individual. So the polarity is opposite, so you'll make some sense going forwards. So captured 130 kind of cases, of which only 99 had complete data. The male-female ratio is about 1.2 to 1, and they had similar kind of mean ages of both genders, and that's all the demographic data that I had. So just to sort of interpret this graph, so you'll see on the far left, kind of over here, these are the kind of the healthiest patients, and then these are the patients with the worst pre-op scores. And as intuitively you'd expect, patients with the worst scores have the greatest improvement. But what this model has tracked and has given us a 95% confidence band is that it's not until you hit a sort of a pre-op ODI of being greater than 22 that you're actually predicted to benefit with 95% certainty from the surgery. So potentially, there's a now suggested figure. If your ODI is less than 22, then you could be left worse off or not benefit from the theatre. And that was a statistically significant correlation. And it's much the same case for EQ-VAS, where on the far left, these are the healthiest patients, and on the far right, these are patients with the worst pre-op scores. There's a strongly significant kind of correlation between pre-op score and the 1-year post-op difference. And again, there's a threshold here where it's not until your EQ-VAS pre-op is less than 60 that you're predicted to benefit from surgery. So you can see here, there's quite a few patients that are actually left worse off 1 year post-op, despite having the surgery. So I guess some context for these figures is obviously something that we care about as clinicians as the minimally clinically important difference. And so these are some widely kind of reported, but some recent literature states 15% and 7% for sort of ODI and EQ-VAS respectively. So not just to have a statistically significant chance of improving surgery, but to have a clinically appreciable improvement. We also suggest values of ODI of greater than 65 or pre-op EQ-VAS less than 51 in order for us to have a patient come back and there'll be a noticeable improvement clinically. And also some sense checking. So the pre-op cutoff value of 22 to produce an improvement is actually similar to the patient-accepted symptom state scores produced by us, which quote 25. So obviously some limitations to my study. It's a single center study. There are many other variables I appreciate that go into listing and prioritizing a patient. such as duration of wait and the consequences on the quality of life. Limited to 1 year follow-up, I didn't analyze the patient's osteofollow follow-up, and the questionnaires that we used at the time didn't actually account for leg or radicular pain, which is commonly the main indication that surgeons use when listing patients for decompression. So in summary, we state some common sense stuff here, I suppose, that the patients with the most severe problems are likely to have the greatest benefit. But interestingly, if you have pre-op values of less than 22 ODI or greater than 60, then you may not benefit from a single level lumbar decompression, whereas it has implications on patients being seen in sort of spinal hubs where they're seen by an advanced practitioner, physio, for example, with an MRI, they might show a single level, and then you may need to consider, is this person worth putting on the waiting list to see a spinal surgeon if they're not likely or predicted to benefit, and then even more so for slightly higher thresholds, in order to have a clinically patients with pre-op ODIs greater than 65 or less than 51 may have clinically detectable improvements in their 1 year post-op scores. So these are the references that I discussed.
Thank you, Mr. Duffer. We'll stop.
And thank you very much.
Wonderful. We have quite a tight schedule, so we've got time for one question. If anyone in the audience would like to ask, we've got a microphone at the front here, and we now have one at the back as well, if anyone would like to come forward and ask a question of the staffer.
I'll ask a question if that's okay, if no one's going to the mics. So your recommendation is patients should have an ODI of greater than 65 before considering surgery. That seems very high when you look at the literature and surgical cohorts.
I'd probably, as far as making suggestions, use the lower of the two figures. So I'd use 60 for EQVAS and so 22 for ODI. And yeah, I don't know. Obviously, it's a relatively small amount of data, only 130 patients, or 99, sorry, that went to analysis. So yeah, I wouldn't say as high as 65, but I think it's probably helpful for people fall into that niche category of actually only having mild symptoms, seeing and having an MRI which shows some more organic pathology there, but to empower the practitioner seeing them to be able to say, well, there's some data here that shows that you're not actually, you could be left worse off, and so maybe come back or see how you get on with physio, and that will, and then having had that discussion, that probably empowers both parties to see how they progress and come back or again put onto the waiting list to see a spinal surgeon if they need to.
Okay, thank you.
Thank you very much.
Thank you.
And could welcome our next speaker, Kay Raftery.
Hi, yes, I'm Kay, a PhD student at Imperial College London, working in collaboration with the Mayo Clinic to understand apophyseal ring contact as a predictor of end plate subsidence following transforaminal lumbar interbody fusion. And just to note, we have no conflicts of interest. So transforaminal lumbar interbody fusion, or TLIF, is an approach whereby the interbody cage is inserted in the posterolateral direction. And currently, the risk of end plate subsidence following TLIF is higher than any other approach. And we know that subsidence is linked to various other postoperative complications, such as non-union, pseudoarthrosis, loss of intervertebral height, and even the recurrence of painful symptoms. And in TLIF, it's especially crucial to optimize cage placement, since the surgical window and cage footprint are relatively small. And many clinical studies have shown that anterior placement of the cage, or greater center point ratio, reduces the risk of subsidence. And equally, biomechanical studies have shown that the peripheral region of the vertebral end plate, known as the apophyseal ring, is stiffer and stronger than the central region. And we could then hypothesize that more anteriorly placed cages are synonymous with greater apophyseal ring contact. We can harness this stronger part of the end plate to reduce subsidence risk. But this has never been shown in a patient cohort before. So the overall aims of this study were to compare cage apophyseal ring contact between categories of subsidence severity and evaluate apophyseal ring contact as a predictor of subsidence. So data from a cohort of 167 patients were retrospectively acquired from a multi-center institution, and this included both preoperative and postoperative CT images. We then applied an inclusion criteria to control for any surgical characteristics thought to influence the mechanics at the index level. And this then resulted in 42 of those patients being eligible for continuation with the study. And subsidence measurements were then performed on the post-operative CT image based on the maximum amount of subsidence at both the suprajacent and subjacent end plate. And we then categorized these patients based on their subsidence severity, where no subsidence was less than 2 millimeters, moderate was between 2 and 4 millimeters, and severe subsidence was greater than 4 millimeters. So we then developed a pipeline to quantify the contact area between the cage, the end plate, and the apophyseal ring. So first, we segmented the end plates from the preoperative CT images, where the apophyseal ring was manually defined based on the patient's specific anatomy. We then registered these preoperative end plates to the cage positioning in the post-operative image, and then we meshed the corresponding contact area. So now on to the results. We found that patients with no subsidence had significantly higher contact between the cage and the whole end plate relative to those that severely subsided. But not only this, we found that these patients showed significantly higher cage apophyseal ring contact surface area and relative contact percentage, and this was relative to both those that moderately and severely subsided. And then we performed a stepwise linear regression to predict the subsidence depth, and we added other surgical and patient factors as covariates. And we found that whilst apophyseal ring contact percentage was a significant univariate predictor of subsidence depth, cage length, center point ratio, and vertebral Hounsfield units came out as the most significant in the multivariate model. Finally, we developed a probability curve to estimate the risk of subsidence as a function of contact between the cage and the core region of the end plate. And this suggested that a 54% contact with the core region, or 46% apophyseal ring contact, was associated with a 50% probability of subsidence. So to conclude, our results support that cage apophyseal ring contact can be used to predict post-operative subsidence, only supplementary to other clinical predictors. And this knowledge could promote more leniency when placing cages in the intervertebral space and could optimize surgical pre-planning by targeting localized, thicker regions of the apophyseal ring. And it's also interesting to observe that there was no significant difference between cage apophyseal ring contact between moderate and severe subsidence patients. This suggests subsidence severity may be more dependent on things such as bone quality, and this hypothesis was supported by a post-hoc evaluation of Hounsfield units at the cage contact site. So thank you very much for listening, and I'll be happy to take any questions.
Thank you, Kay. We've got a question.
Yes, Ed.
Hi, Alistair Hudd, Ipswich. Thank you very much. Excellent, thank you. Having now reflected on the Hounsfield units and knowing that that is now kind of out there as a unit, have you gone back and looked at your pre-ops and calculated their Hounsfield units and gone, should they have had a TLIF in a cage in the first place?
Yeah, I guess this sort of knowledge can also stem back to the approach that you do use. And I guess these patients probably were filtered for their approach based on patients that may have had a relatively much lower Hounsfield unit than these ones. So as much as I can't really answer your question as that.
Could it be the next stage of this is to go back and do a retrospective look and you can add it to the data?
Yeah, I mean, there could also have been factors within this patient cohort that meant that TLIF was the best indication for them. And Hounsfield units may have been like a minor factor in that. But yeah, I do agree that the Hounsfield units could have, ultimately decided the approach.
Take one more quick question.
Yeah, quick.
Sorry, it's not very, very long. So the problem is the issue of subsidence and clinical relevance. So, biomechanically speaking, you would say that a PLIF, where you have two cages, is much better than a TLIF. But then when you have a TLIF, you have so many different cage configurations, and every day you come up with a bigger cage, you have banana, you have, hockey stick, you have expandable, non-expandable. So basically what I'm saying is that all of that, does that have a relevance to the clinical outcome? And did you look at that, and is that important?
Okay, yeah, so we factored out, so cage material, we just included titanium cages. We looked at both banana-shaped and bullet-shaped cages. We found that in a previous paper that was published by our collaborators, they did find a difference between bullet and banana-shaped cages in subsidence, and that is something that, you know, I might go on to look at and just pick apart the cohort to see if that's actually having an effect. But in the linear regression model that I performed, I did include these as predictive variables, and they didn't come out as the most significant in the final iteration of the stepwise model.
Thank you.
Okay,
Kay.
that's lovely. Thank you.
Great. I think I need to be careful not to remove too many Hounsfield units when I'm preparing the end plates, is one of the messages I'm going to take away. So if we welcome Ghazal Montazidian, I apologize for my poor pronunciation. Going to talk to us about epidural fibrosis during primary microdiscectomy.
Okay, good afternoon everyone. My name is Ghazal. I'm currently a fourth-year medical student at Cardiff University. So today I'm going to talk about our service evaluation with the purpose of finding out the prevalence of epidural fibrosis following primary microdiscectomy. And there is no conflict of interest. So, epidural fibrosis. That's basically the formation of scar tissue in the epidural space around the spinal cord. Key causes include surgical trauma, inflammation, infections, and there are many various ways that we can minimize this, such as minimally invasive surgical techniques like microdiscectomy. So, this retrospective study focused on a 10-year analysis at the Cardiff University Hospital, Wales. We looked at patients undergoing single-level primary microdiscectomy at the L3, sorry, I'm a bit nervous, at the L3 to S1 lumbar spinal levels. And our criteria yielded 241 patients. So, our table shows the patients in our criteria looking at 2013 to 2023, highlighting those with repeat MRI scans, recurrent disc herniations, epidural fibrosis, and those who had revision surgery. Table number 2 shows the incidence of epidural fibrosis and those who had revision surgery. Analyzing our results, 47% of our patients came back with recurrent symptoms varying from sciatica, cauda-equina syndrome, and paresthesia, and therefore had repeat MRI scans. And in total, 19% of our patients had epidural fibrosis as seen on MRI. Now, given the retrospective nature of our study, we do acknowledge that there is an underestimation of the prevalence of epidural fibrosis because not all of our patients had MRI scans. In total, 20% of the patients underwent revision surgery, and 94% of those was due to recurrent disc herniation. And 50% of the patients who underwent revision surgery were found to have epidural fibrosis. A particular trial that I looked at was the sports trial, which was a multi-centered randomized control trial done in America, which looked at the outcomes of surgical versus non-surgical treatment of lumbar disc herniation. So their revision rate after 4 years was 10% in comparison to Cardiff's revision rate, which was 20% across the 10 years. Now, as you can see from the chart, there's a declining incidence of epidural fibrosis across the years, which was confirmed by a Pearson correlation coefficient of -5.6. A chi-squared test gave us a p-value of 1, which showed that there was no significant association with epidural fibrosis and an occurrence of revision surgery. This decline could be due to various factors, one of which being the discontinuation of Adcon gel, which is a barrier adhesion gel previously used in surgery to prevent scar formation, but recent literature has shown that it's actually pro-inflammatory. and so this was discontinued in 2016. Furthermore, epidural fibrosis develops over 1 to 2 years, and so the patients in the later years would not have had sufficient time to be followed up and have any repeat MRI scans. So to recap, the incidence of epidural fibrosis was 19%, and the incidence of symptomatic MRI-proven recurrent disc herniation was 44%. And in conclusion, the prevalence of epidural fibrosis has significantly reduced in the last 7 years. Thank you.
Thank you very much, Ghazal. Well presented. Do we have any questions from the floor? Yes, Kaushik.
Thanks, Ghazal. I'm Kaushik from Preston. Very nice, very relevant, because we all encountered this problem day-to-day basis. Now, you mentioned about discontinuing at Congel, so are you, or your center is using some other stuff at the moment?
I'm not aware that they have replaced Atcongel with something else, but I know that they stopped using it after 2016. I think there was some talk about something called Flossio as well, which could prevent bleeding, but I'm not sure if that's being used either.
Purpose of Flossio is different. I mean, I use a different one, and my impression so far is it reduces the scar tissue, which I might be completely wrong. So it's a very interesting, and it will be good to follow this up for.
It's interesting, isn't it? Because it coincides with the timing of the reduction in the fibrosis rates. Are there any other specific factors within the unit where you did this study that might be the reason for that reduction in epidural fibrosis?
So that's also data that we're looking at. Because this was a retrospective study, there isn't concrete proof, it's just theories. So I know that 2 of the surgeons in the department started using microdiscectomy, I think after 2017, but again, we'd need to look at those patients under the care of those consultants separately. So for this, really, it should be a perspective.
So you're favorably calling it an improvement in surgical technique over time?
Not because you started endoscopic discectomy at that time.
Thank you. We'll stop there.
Yeah, I think
Thank you very much.
We'll move on to the next speaker, if that's okay. Thank you. If I could welcome our next speaker, and we have Mohammed Junaid Khan, talking about early post-operative complications in lumbar spinal fusion surgery.
Hello everyone, my name is Mohammed Junaid Khan. I'm trauma and orthopedic registrar in Gloucestershire Royal Hospital. I'm presenting a study named Early Post-Operative Complications in 1 to 2 level lumbar spine fusion. Surgery is high volume, low complexity surgery, spine surgery straightforward. There is no conflict of interest to declare. Lumbar spine fusion is a commonly performed operation in spine units all across the NHS. Common techniques include posterolateral fusion and transforaminal lumbar interbody fusion, which is commonly known as TLIF. It is considered as a high volume, low complexity surgery and audited through GIRF. Common complications that are associated with this surgery include incidental durotomies, wound complications, hematoma formation, and medical complications. We looked at the hospital episode statistics for 185 consecutive patients who underwent lumbar spine surgery in our unit between May 2021 to April 2024. All 1 to 2 level lumbar spine fusions were included in this study. The female to male ratio was 112 to 73 with a mean age of 67 years. And we looked at all the reasons of representation, readmission, and complications in these patients and classified them by Clavien-Dindo classification. Clavien-Dindo classification is a widely used system that reports post-operative complications and grades them according to the level of intervention required to treat them. So the higher the level of intervention, the higher the grade. Just to summarize, there are 5 grades. Grade 1 is one that is deviation from the normal postoperative process, which is without the use of endoscopic, radiological, surgical, or pharmacological intervention, except for antipyretics, antiemetics, analgesics, fluid resuscitation. Wound management on bedside, not without any anesthetic, is also included in this. Grade 2 is pharmacological management with medications other than the ones included in grade 1. Grade 3 and 4 are most relevant to our specialty because they include intervention. Grade 3 is when there is endoscopic, radiological, or surgical intervention required, be it under local anesthetic or general. Grade 4 is the one that are life-threatening complications requiring intensive care admission, while grade 5 is death of a patient. 21 of our patients out of 185 re-presented to our trauma assessment unit, which is a day assessment unit for trauma orthopedics and spine. But only 13 of them, that makes it 7% of the total, were readmitted. There were also 8 cases of incidental durotomy, equally distributed between TLIF and posterolateral fusion, but only one of them required surgical intervention washout, that is 3B. This graph shows the readmission patients. So we had 6 patients who had wound complications. 3 of them only required antibiotics. The other 3 required a washout. Whereas there was 1 patient with a cardiac event and 1 patient died of respiratory tract infection. Our study shows that the importance of being cognizant, the clinicians being cognizant to the complications associated with lumbar spine fusion. It is high volume operation, but not always low complexity because it's not that straightforward. There are complications reported, and we have similar findings in our study. It also highlights the awareness of the complications that are associated with it and the importance of preventable risk factors to prevent these complications. What can we do in this case to reduce the risk of complications? Coordinated MDT setup is the way to go. So patient information is critically important because some of the patients that presented that were not readmitted but discharged came back with pain. So patient information with leaflets, with informative letters, and information about the resources by BAS, that is spinesurgery.ac.uk, are helpful. In addition, patient selection is extremely important. So we should focus on the patient selection and to reduce the preventable risk factors so that these complications can be reduced. In all surgeries, adhering to principles of surgery and meticulous surgical technique is important, but it's paramount in spinal surgery, so that is something to focus on. And optimal post-operative care also helps reduce these complications. Thank you.
Thank you very much. Lights on. Anyone coming to the mic to ask a question? Mohammed? I'll start with a question, if that's okay. I'm over here.
Of course, yeah.
So your last slide mentioned about patient information sheets. Is this something they routinely get before surgery, or are you talking about tweaking or adapting the information based on your study?
We have included that in our practice. So we give patient information sheets, and also all the risk factors, pros and cons of the operation are in their letter that is posted to the patients. In addition, the spine surgeons go through the same on the day of the operations and answer any questions if present. We also paste the website address spinesurgeons.ac.uk on all letters. So that I think has helped our practice, and we would recommend that.
So I can see that's a good way of reducing your inappropriate readmissions with patient education. What would you do about reducing the absolute complications that you picked up?
So the ones as in my last slide include patient selection and preventable risk factor reduction. There are several papers that show preventable risk factors, which include diabetes mellitus, COPD, preoperative hematocrit, hypertension, smoking. So those can be optimized before the patients come to the operation. That is something that can be done preoperatively.
Do you think that should then affect whether it's classified as a low complexity procedure based on that stratification then?
Yeah, we think that it is low complex.
think
It is
about it.
classified low complexity, but we think that it's not that simple. There are complications, and the clinicians must be cognizant of it because they are reported widely in literature, and that is what we also found out in our study, which is what we want to tell our audience.
Thank you very much.
Thank you.
Thank you.
So if we could invite our next speaker, Mohammed Adnan. Thank you.
I'm a spine fellow at the Oxford University Hospital. So basic topic of discussion is about the spine awake surgery. We all know much about this concept that's been known for some time, but we've seen that it's not really adopted in our spinal community. So the spine awake surgery is basically doing the spinal surgery under regional anesthesia rather than under general anesthesias. Predominantly is done in the lumbar regions, and it's been done in some upper regions as well, but predominantly it's in the lumbar spines. So in spine awake surgery is basically the spine surgical procedure under the regional. Among the regional, we do use the spinal anesthesia as well as the clip blocks for the purpose so we can discharge the patient more quickly and we can reduce the length of stay of our patient. Basically, this is just the continuation of our previous talk that we did in the last BIT meeting. So SAS basically is to look into the complications that's not well noted after having the general anesthesia, and among them is the post-op hypokinetic delirium, which is much more common in the older age patients who have gone through the lumbar spine surgery quite often due to this degenerative process. And if we look at the literature, all the patients who are above 60, they are much more higher chances of having the post-op hypokinetic delirium just because of these hemostatic changes within the body after having the general anesthesia and the sedation. So that's our protocol of SAS is. Basically, the patients usually come on the day of surgery. Anesthetic team and the spinal team meet the patient, and we usually do that procedure as a day case, and the anesthetic team do the spinal anesthesia in the sitting position as a hyperbaric bupivacaine with the analgesic as fentanyl. And once we get the proper level of blockage, we put the patient in prone position and do the clip block, and then we do the surgical procedure. Basically, through the procedure, this patient is quite awake, interactive, and without any sedation. Usually the patient go home after ticking few boxes, like patients start to take something orally, passing water, and mobilizing without assistance if the patient was having the same mobility status before the surgery. And very important bit is we usually give a call to the patient as an early post-op follow-up just to see how the things been going on. So these are basically the potential benefits of SASs. As I mentioned, is predominantly we're looking at the post-op hypokinetic delirium, as well as I mentioned, it just enhances the recovery and the rapid discharge of the patient. Also, we are looking at the pool of the patients. Can we increase our routine lumbar surgical procedure to change into the SAS protocol so we can do this procedure as a day care, as well as we are looking for the cost effectiveness of our SAS procedures. This is a very early survey. Basically, we have done few cases after this survey, and if we look at this survey, this is about the early few patients we've done initially, and it did show quite a significant number of satisfaction during the procedure and even after the procedure. So the purpose is basically we look at our own data during the last 2 years, just to looking at the simple lumbar surgical procedure, just to find out how many cases we did as a daycare and how many cases we did overall, and how many patients stayed in the hospital for a longer period of time. And also we try to segregate out about the factors that's affecting the patients and hinders their discharge after general anesthesia. So these are basically the data is. So we did operate about 144 simple lumbar laminectomies and discectomies over the last year, and this year we did about 116 so far. And among those cases, we did in total 42 cases. Among those are 23 we did last year and about 19 so far this year. That's the most important graph is. If we look at this graph.
Summarize and close.
Yeah, sure. This graph shows that the earliest the patient go home is during the initial 4 days. So looking at this graph, about 70 to 80% of the patient can go home during the initial 4 days. Why can't they go home on the same day? So looking at the factors, these are the predominant factors that hinders their discharge on the day of surgery.
Right,
and
we'll
it takes
stop you
few
there
days.
if that's right. We can leave that slide up.
Just
so
the
people
last
can read
slide
it.
coming up. So the main importance is just saving some money, and that's the take-home messages.
Okay, we'll leave it on that slide. Thank you
Yeah,
very much.
sure.
Do we have any questions? Did you look at patient satisfaction at all as part of your assessment here? So you've looked at a number of different variables, and how did patients feel about the surgery?
We did a survey about the patient satisfaction, and it did show like about 80% of the patient was quite satisfied day after the surgery, and about 90% of patient was even quite comfortable during the surgery because they was completely awake.
Very good. Kausha?
Thank you for your presentation. It's a good topic. You have shown a good number of patients couldn't go home on the same day, which you planned as a day case, which is slightly different our experience, because patient selection is very, very important, which you are selecting for day case. But my question to you is, with the spinal anesthesia, sometimes what we find is the extended length of their postoperative recovery of the legs from the anesthesia itself. And that sometimes could be detrimental of sending them home quicker. What is your experience on that?
Basically, we do use hyperbaric anesthesia. And that
Could you stand by the microphone for us? Thank you.
And that anesthesia usually lasts about 120 minutes to 150 minutes. And sometimes we do start to feel sensation by the end of procedure. That's the beauty of hyperbaric is. So the patient can start feeling by the end of procedure. All right? It's not like the simple spinal anesthesia which lasts for a few hours. It's just the hyperbaric component is that lasts just hardly about 2 hours, 2 to 3 hours.
That's interesting.
Thank you very much. We'll carry on the discussions after the session. Thank you.
Sure, thank you.
And our next speaker is Leanne Wood. Welcome, Leanne. She's going to talk about mediators of the BOOST intervention on walking function.
Thank you. So I'm presenting our provisional results at the moment. We still haven't quite finalised them, so do bear with me. And I'll be touching on the BOOST study, which Esther Williamson will be talking about on Friday morning. So if you'd like to know more about the BOOST programme of work, please do come to a talk on Friday morning. So these are our conflicts of interest. We did get some, I have been supported with some funding. But essentially, the BOOST trial focuses on community-dwelling adults who had a clinical diagnosis of neurogenic claudication, and they were recruited from secondary care and primary care sites. They weren't deemed to be suitable for surgery, and I think it's important to understand in terms of this cohort. And we undertook a causal mediation analysis, which aims to use statistical methods to try and explain what the underpinning mechanisms are of how a treatment may work. And the hypothesis was that the BOOST intervention would reduce pain-related disability at 12 months, in part by improving walking capacity. So this study aimed to try and understand which of the potential proposed mechanisms of the boost intervention created an effect on walking disability at 12 months. So just as a quick overview, the boost trial consisted of the boost intervention, which had a 60-minute initial appointment with group discussions, an exercise circuit, a walking program, and some phone calls to follow up over a 12-week session. In contrast, we had the best practice advice group, which again had an initial appointment and consultation, but this group, in contrast, were given self-management advice, some 4 home exercises, and potentially up to 2 reviews if these were needed. Christine Comer led on the proposed the protocol for this work and identified the proposed mediators, which, as you can see in the green box, are walking capacity, fear avoidance, symptom severity through the Swiss spinal stenosis pain and neuroischemic scores, physical performance, and walking confidence. And initially, there was a lot of work done for the BOOST program, where they did a lot of intervention development work using patients and public and clinicians, and they really postulated that the primary mechanism through which the BOOST program would make a change would be through the change in walking capacity. Now, there were potential confounders, obviously. With any causal mediation model, we consider what are the things that could impact the results or impact any of these pathways. And you can see here we've controlled for many different confounders, including age, body mass index, gender, baseline frailty, baseline grip strength, general pain, attitude to aging, baseline exercise scores, and then all the other baseline mediator model, baseline mediator variables. To just touch on the trial results, so the best practice advice group and BOOST group were similar in age, and they were predominantly female, so 56%, 58% of the groups were female. And there were significant differences in the walking subscale of the Oswestry Disability Index at 6 months, and at 12 months these were slightly smaller, but they were both statistically significant. And when we look at this mediation analysis, what we've done with it, instead of using the ODI as a total score, we've used just the walking component subscale. So we've taken the 5-point ordinal variables, and you can see that these aren't statistically significant, but there is a trend that the BOOST group, basically the BOOST group had a greater chance or greater likelihood of increasing their walking ability. So what we see with the mediation analysis results, and these are slightly different to normal presentations because it's an ordinal regression, not a linear regression. You can see that walking confidence appeared to mediate most of the pathway by mediating 41% of the change in walking disability, and 32% of the pathway was done by the Swiss spinal stenosis pain severity. But what we can also see is that the combined indirect mediation of all these proposed mediators actually mediated 94% of the change. So this is a really interesting finding because it suggests that it's not just the one thing on its own, it's all of those things together that appears to have the greatest change. So the clinical implications is that clinicians and researchers may wish to use the walking component of the ODI more frequently in future, and Manuela Ferreira's study on lumbar spinal stenosis in Australia is using that as their primary outcome. Walking confidence and symptom severity appear to be the key mediators, but it's unclear what the temporal relationship is. So is walking confidence needed for the pain to reduce, or does pain need to reduce first for walking confidence to change? And these may be mutually beneficial. And in other studies, we've seen that people living with neurogenic claudication have previously reported that that pain of neurogenic claudication was the primary thing that bothered them. And if they had to choose, they wanted that pain to reduce rather than necessarily choosing to walk further. So an interesting finding, and essentially this study shows that the overall combined indirect effect was greater than any of the single mediators. So actually we're looking at that biopsychosocial effect is probably the most important thing. So considering multi-component treatments for this patient group is important. Thank you very much.
Thank you, Leah. Yeah, thanks, Leah. Got a question?
Thank you, lovely. Alistair Hudd, Ipswich. Following on from that, this is almost like, have you then considered surgical patients and what this does to the outcomes if they then go on to surgery, or is that for next year?
We've done a little subgroup of, because the BOOST trial ran with follow-up data for 2 years, we have looked within that cohort who converted to surgery, but we don't have post-operative outcomes.
Okay, because that would be useful, whether this is a very useful prehab for those patients that we're going to put on the list.
It wasn't the intention. It wasn't. I think prehab is another piece of work we'll be talking about tomorrow. But I think prehab is often quite different to conservative management, and that it's quite tailored to how to optimize surgery. Whereas these components may well be useful in a prehab, but they probably need to be reformatted to be, this is how we can help you with surgery, as opposed to, this is how we can help you manage your symptoms.
Thanks.
Thank you.
Any further questions? Oh, you're gone. Okay. Well done, Jan. Thank you.
Thank you. So if we could welcome our next speaker, James Warren.
Good afternoon. I'd like the opportunity to talk about a injectable peptide glycosaminoglycan hydrogel for minimally invasive nucleus pulposus augmentation that we've developed at the University of Leeds. So, recent medical advances suggest that nucleus pulposus augmentation or replacement as an early treatment for disc degeneration may be appropriate treatment. However, the challenges of the initial products were expulsion of these materials or subsidence. So the criteria for these devices should be that they must be injectable without disrupting the annular tissue. Can it be compatible with the native properties? And can it replicate the function of the healthy nucleus? So at the University of Leeds, we developed a peptide, or self-assembling peptide, glycosaminoglycan-based hydrogel. And the rationale behind that was that at the early stage disc degeneration, you see gag reduction, which can influence the loss of the swelling pressure within the disc, which can lead to altered biomechanics. So we thought that if we can restore the gag content using this hydrogel, could we restore the biomechanical function of the disc at the early stage to prevent further degeneration? So what are self-assembling peptides, hydrogels? They comprise of 11 naturally occurring amino acids, where at the moment we have a family of about 34 different variants, where we selected the most appropriate to take forward for this application. And when we combine them with GAGs, specifically chondroitin sulfate found within the intervertebral disc, we can form that hydrogel. The combination of these two doesn't inhibit that ability to gelate, and we can inject these down narrow gauge needles, so smaller than 29 gauge needles, and they gel instantaneously in a way that is reversible if we want them to be, but for our application, they will form a very stiff, mimicking the nucleus pulposus itself. So the most important part of our device is the ability to restore the biomechanical function. So when we've looked at developing a sequential testing methodology using bovine tail specimens, where to get our early stage degenerative disc, we enzymatically digested the tissue to try and form that early stage degeneration. We've carried this forward in a large amount of testing, so greater than 50 specimens, from a range of 100 to 20,000 cycles of loading. And in all of these loading conditions, we found that the biomechanical behaviour of the disc is restored to that of the healthy levels following the augmentation with the peptide GAG hydrogel. And in this case, we were able to inject the gel down a 30 gauge, 10 centimetre bespoke needle, where you can see here, where we can see the green line on the blue line, that it's that replicating that of the native tissue. But a lot of the work preluding this is that we needed to develop understanding how do we inject, what's the needle orientation, and designing that needle. So we looked at whether or not could we have the two needles in 120 degrees apart or parallel, and we found that actually being parallel to each other got the most turbulent mixing. And in this case, you can see that from the green mixed gel on the right-hand side. The fact that it mixed together better, the better green colour we could see, the less separation we had between the GAG and the peptide component. But we also had to develop a bespoke needle to be able to inject this with the idea of not having an incision. So we had to work to develop a long gauge needle that we were capable to inject this down. And you can see this is our early design here, where we were able to put it through a syringe driver to replicate that would be injected by a clinician in clinic. We also looked at, these are quite translucent gels normally, without a dye. So we looked at combining them with a contrast agent to be able to visualize these fluoroscopically. in clinic. So we chose a FDA-approved contrast agent, in this case Ultravist, but we've looked at also using Omnipaque, where the pre and post CT images there, you can see where that white nebulous structure is. That is our hydrogel without having to open the disc post-injection. We can see that it restores disc height as well. Going forward, taking this, we needed to look at being able to do some biocompatibility testing. So we did some significant amount of in-house compliant with ISO 10993. We also got it validated by a CRO, in this case Wickham Laboratories, to validate that were our gels biocompatible. So we've done a combination of direct and indirect contact cytotoxicity testing to show that our gels can be safe in the body. So to conclude, we've developed a hydrogel at the University of Leeds that meets the biomechanical and clinical requirements for nucleus augmentation with the following results, where the GAGs increase the peptide gel stiffness to replicate that better of the nucleus pulposus that are capable of being injected down long, small gauge needles. The peptide GAG hydrogel restored the stiffness and disc height to healthy native levels in vitro testing, significantly different from that of our in-house degenerate specimens. We've also been able to show that we can include a radiopaque agent to be able to better visualize the gel within tissue and also demonstrate its biocompatibility. Finally, we're welcoming the feedback from people in this audience. So if you could take the time to either scan the QR code for a little survey just to give your feedback of what your opinion of our technology is, or if you want to see more, come and visit us stand 14, where we can talk a bit in more depth about what the technology is. Thank you very much.
Thank you, James. So do we have any questions from the audience? So a question from me, James, as an ignorant surgeon. Are we going to have to look at changing the environment around which this injectable is injected in order for it to work? In terms of any hydrogel that we inject into the disc, will it work in all settings in vivo, or are we needing to look at combined effects? So is this part of the solution, or do you see this as being the whole solution?
So during our development, we've looked at what clinicians have available. So we've tried to develop it so it can be readily used, but it has a really wide range of working properties in terms of the pH of the tissue, the temperature, other components. So we looked at both native and all the way to quite severely degenerate, and it does gelate in all of that. So we've tried to optimize it for as many properties as we would see in vitro to replicate that you would see in clinic.
So you see this as a standalone solution?
Yeah.
Okay. Thank you.
Thank you very much.
Thank you. Can we have our last speaker on the stage? You're doing awesome timekeeping. Well done. Anastasios Benjamin Conteos.
Hi, good afternoon. My name is Benjamin Conteos. I'm a clinical fellow working currently at the Walton Center, and today I'm going to be presenting the long-term results of the NERVES trial when comparing surgical microdiscectomy with transforaminal epidural steroid injection for the treatment of patients that suffer from lumbar radiculopathy secondary to a herniated disc. I have no conflicts of interest to declare, and just to summarize, previously the NERVES trial ran between 2015 and 2017 with a paper published in Lancet in 2021 in which they compared two groups that received two different interventions, one surgical and one transforaminal epidural injection for the treatment of radiculopathy. The authors concluded that at 18 weeks follow-up, they had similar outcomes in terms of patient-reported outcomes. And given that both the microdiscectomy and FESI is safer with fewer complications and cheaper, then it is a reasonable alternative to offer patients that present within the first year of lumbar radiculopathy. And it's important to mention that those patients that don't receive treatment early on, a substantial amount, 30%, will go on to have chronic problems, which will then impact on their ability to work and also lead to more interventions, maybe more aggressive, which has the financial implications on our health system and social care system. So our methods basically mirrored those of the original trial, and the patients were recruited from those from the original trial. There was a £20 Amazon voucher to incentivize patients to reply to our survey. And our exclusion criteria including the following, apart from age, because the original trial was between 16 years of age to 65, but we wanted to capture those patients that at the time of trial was 65 and now would be much older. We used the Osmond's 3 Disability Index questionnaire in order to assess our primary outcome, but we also used a number of secondary outcomes, including patient-reported outcome COMI, the numerical rating score for pain, both in back and leg pain, and also we looked at any reoperation rates and followed these patients. So from the 163 original patients, we recruited 80 patients at the Walton Centre and followed 76 which met our criteria, and we had 32 responses, meaning a 42% response rate. Out of these, 27 were included because one did not want to share their data, and the others had incomplete data, which would skew our analysis. And from these, 15 had received surgery, and the other 12 had received the injection. There was a male to female ratio 1:2, and when we broke down what happened to them over the period of follow-up, those that originally had undergone surgery, 75% did not require any other intervention. Those that had initially undergone the injection, we found that only 40% of those did not require further intervention. And from the surgical group, those that did need another intervention did so 100% in the form of surgery, whereas those that from the injection pathway, 76 had surgery and 13.3% had another operation. We compared those patients that did not require any further intervention to assess their outcomes, and we determined that from the time of procedure or intervention to the time of follow-up, that 7 years had elapsed. So we're basically looking at 7-year outcomes here. So our primary outcome showed that there was no statistical significant difference between those patients that received steroid injection versus those that had surgery at 7 years. But we need to note that the reported outcome was significantly worse than that reported in the original paper. Secondary outcomes included that the overall recurrence rate of leg pain was 59%, and we can break that down into 66% for the surgical arm and 53% for the steroid injection arm. Gender did not affect recurrence, and the greatest recurrence rate was found in the 40 to 50-year-olds. And the mean time between first and second intervention for those that actually needed a second intervention was 190 days. So in conclusion, all our secondary outcomes showed no statistical significance when comparing the two arms. However, there was a small prevalence for improvement in leg pain from patients that received surgery, and this is the satisfaction rates. And then, as a conclusion, in both arms, we had a lot of recurrence and requiring further interventions. However, the surgical group seemed to fare better than the non-surgical group in terms of requiring a further intervention. So that poses the question whether, if we were to apply the incremental costs acquired over time with patients that had initially an injection and then the follow-up and then further intervention, whether that's still cost-effective or not. And we would need to apply that model.
Thank you very much. Has anyone got a question? I'll ask one. I'm really excited to see those that follow-up data. Thank you. So you mentioned in your last slide about better patient selection. Might avoid these outcomes.
Not exactly better patient selection, but the problem we have is with follow-up. So a lot of patients, as you saw, we only had 42% compliance, and we were wondering whether that introduces a bias, because it seems that those patients that responded are the patients that fared worse than the patients that did better. So I think a lot of patients fall out because they do well and then they have no incentive to be followed up or to commit to another clinic or a follow-up session. So I think there is some bias in that result there.
Yeah, great. Thank you.
Thank you. So thank you very much, everyone. Thank you to our speakers. And we'll hand over to the next session. Hello, good afternoon. My name is Sudarshan. I'm one of the spinal surgeons at Alder Children's Hospital and Oswestry, and I'll be moderator for this session, along with...
My name is Nitin Shetty. I'm one of the spinal surgeons at Whittington, London.
The first person I would like to call upon, Mr. Pat Kiley. He's a distinguished surgeon at Our Lady's Hospital, Children's Hospital in Dublin. And I know Pat quite very well. Goes back to 2000 and, if I remember correctly, 2006 when he came back from fellowship to take up a new consultant job in Our Lady's Hospital. I was a SHO there at the time. So yeah, dais is yours, Pat.
Thank you. So the title of this talk was "A Fool with a Tool is Still a Fool," and thanks very much for this invitation to come over from Ireland and give you this experience and some thoughts. So that's Crumlin Hospital where I work. I came back in 2007, so you were nearly right. And right at the bottom of the picture, you can see there's a building site in the hospital. This picture was taken in 2015. So where they were dropping that or clearing the car park, is the pedestal where they were putting a new hybrid cardiac theatre. And at the time, we were experiencing a crisis in spine deformity surgery, particularly pediatric, and this was on the national news and the BBC equivalent of Panorama on a regular basis, and the politicians were very wary of the issue. So somebody slipped a memo or a draft, which never was published, to the incoming Minister for Health, Leo Varadkar, suggesting perhaps a modular theatre or something built out of scaffolding, or maybe they could put a theatre on top or next to the cardiac theatre while he was coming in as Minister for Health. And he agreed to do a TV interview, but he stalled the interview for 2 months so the project could get started. And that's how we got a spine theatre. At the time, we had been doing 30 to 40 spine deformity cases a year, and we were way under providing. We had a 2-year waiting list. These are my disclosures. So now you can see we're moving to the new great spaceship from the sky, the new hospital, which is being pushed back month after month. So it's finally got due to open next summer, and we'll be glad to host some of our spinal friends from the rest of Britain to come and see us when we're there. But it's a very exciting time. And through this, I've been involved also in looking at new technologies and future-proofing the hospital from the point of view of our practice. So from 2014 to now, you can see we're in a nice shiny spinal theatre with some toys to play with. And just because of the political impetus and the health service impetus for increased activity, there was a big drive on with the election at the end of 2024 to get more cases done, and we hit over 400 for the first time. This is pediatric and adolescent cases, which is my remit and area of responsibility with the rest of the team. Personally, I think well over 100 cases between big ones and small ones, and about 80 plus of them are navigated cases. So I have experience of navigation technologies and of over 300-400 cases at this point, mainly in major deformity. But of course, we're forever learning from our big brothers over here in Britain, and you can see they're publicizing everything on LinkedIn and Facebook or whatever. We're way behind, of course, in terms of robotic spinal deformity surgery. You might recognize these two blackguards. One of them is originally Irish, by the way, but you can have them. So a fool with a tool. Well, yeah, that made me think. Not for very long, so this is the case, just to illustrate. A fool with a tool, not thinking. So this case, at the age of 5, casting was no longer working, her deformity was deteriorating. We opted for magnetic controlled growth rod treatment at that stage. And controversially, over here, they actually worked, and they worked very well. So she, 6 years down the track, has reached the maximum length and excursion with deformity in reasonable control. And we've come to the time point where we have to decide to move onwards. you'll notice her back, her spine is flattened in terms of kyphosis in the thoracic area at this stage. So, so we took her to the theatre, and she had their exposure and the original implants removed. And once that was completed, the new instrumentation was started on the left side early on, because we normally go from below back up the thorax. The screws on the pedicle tracks on the left-hand side led to some irritation of the neuromonitoring. So at this stage, I went over to the left side and we called for the tools. So the fool was me, as we hadn't started with the tools we have to improve the accuracy of what we were doing. And thankfully, we were able to identify problems. You can see from the navigation spin when we did use it that we actually omitted the screws in that area because the pedicles were tiny, almost non-existent. And thankfully, the fool got away with it. She did very well, and she got a nice balanced spine as a result, with no long-term implications. But our tools may have uses. So I suppose the person who thought he was God's gift, or she was God's gift to humanity in 5000 BC, was the person who invented the wheel. And it's funny that it looks like the O-arm, isn't it? But at that stage, that changed humanity, because then they could transport food over distances, they could aggregate into communities, and social cohesion, education, everything grew from there. And we became kings of the world, or so we think. But of course, when we have new technologies and we have new tools, is it always applicable? And we have the choices to decide, when do we invest in it? How do we invest in it? Where do we use it? And there's a big danger that we become slaves to the technology and really then you have to question who's the master. Is it the technology or is it the surgeon? And my earliest experience in coming to Ireland or working in the spine theatre was actually when I was a resident way back in the Millennium era. There was a Braun navigation system which was parked, you might remember it, Sudi. It was parked on the corridor in Tallaght Hospital. It cost 400,000 euros at that stage, and was sitting there as a collector for coffee cups, lead aprons, and the odd bum that needed a bit of a rest, but it was not being deployed. The same is true really for the earlier O-arms in the Royal College of Surgeons Hospital in Beaumont. It was completely under or non-utilised and sat there in a corridor and this was notorious for probably a decade or more. So when you have the tools, sometimes we're not using them, and there are perhaps some reasons why. But you do need to evolve to survive, and to evolve, personally, you need to develop and have the skills and knowledge. You have to have the energy to make the effort, and you need the tools that you need to learn to master to help you get there in your evolution and to solve your problems. And so, as we see, healthcare costs are rising exponentially, and in some of the nice talks earlier today, really a lot of our focus is on trying to maybe mitigate those healthcare costs by reducing length of stay and improving outcomes and improving the safety, efficacy, and lowering the risks of our surgery. So there are our roles for the technological advances which can bring that about, from navigation to imaging to more fancy things like augmented reality and robotic type treatments, and really that's where we're looking for in this discussion. We're looking for improved accuracy through the enabling technologies of the spine, and you can see there are a number of steps in the process, from acquiring the imaging, registering it and referencing it to the patient, allowing it to deploy the tools which make the instrumentation of the spine or procedures easier, and then moving on from that into the kind of fancier high-end stuff. So there are potential benefits from surgical navigation, and they certainly can be related to improved implant positioning, but also from my perspective and from the point of view of the staff, we're constantly otherwise in a radiation flow in terms of the fluoroscopy and the imaging required, and the navigation does allow us to step out of the room, and that's a huge benefit. It does have to be debated as to how much the patient benefits in terms of radiation, sometimes from the imaging. And for every technology that comes, we see this curve, this parabola from Rogers, showing you have early adopters, the enthusiastic people with the new toy, the skeptics, the kind of wider adoption, and then slowly it's being replaced by something else. And maybe that's what happens. And we know the graveyard of medical implants, spinal implants. I'm not sure if you recognize some of these historic devices. I've seen a whole lot of them come and go, and we've seen the technologies come and go, but it's interesting, the navigation machine is no longer in the corridor, and it's now in the corner of the room. From the medical industry perspective, the graph is something very different. as the use of the equipment grows, they're starting to grow their profits, and I suppose they expect a tapered decline in their commercial success of their product eventually across the board. So in key areas for technical development with this technology is within imaging. So the stereo scanner is something that we have in Ireland. We have 3 of them, or the scanner, sorry, should I say, for reducing the dose, because we're very much focused on radiation with the kids. And that has a big, I suppose, discussion point within the theatre and intraoperative imaging sequence. We also are looking at potentially MRI and ultrasound-based ways of non-radiation imaging. And then I'll talk a little bit about MRI guidance and synthetic CT. But the first thing you need to be doing in your operating room or pre-operatively is to look at the quality of the image you need. And standard X-rays are no longer sufficient. So looking at things like CT or MRI, bone MRI, and how you acquire that is one option. But the other choice you have is whether you do that actually in the operating room. And of course, then that's a nice accuracy because your patient is in that prone position. So you're going to actually see the position and anatomy as it's lying there on the table. The images are registered and referenced to the patient, and then everything that's happening is dynamically tracked. So there's a chain of actions. Once you have developed your treatment plan, you have to get your images, you have to get your reference array in position, and then after that, you can decide to merge the images together into a computerized model. And one of the important things with all of these systems is you have to realize that things can shift and move. So you continually have to think about validating that you're still accurate as the case goes on. And that can be technically quite challenging and consuming to get used to that. The question is really, given extensive literature support for many years now about the accuracy of navigation, only 10 to 15% of spinal surgeons are using it. And the question is why? So, of course, it's nice to have a perfect looking X-ray or image in the operating room, but it does take the radiation dose that the patient acquires. It takes, I suppose, challenging your workflow and your established practice. It does definitely involve expense, and it definitely does drive other issues. There's also the question, of course, that you're manipulating the spine when you're doing surgery, and that may shift the accuracy of your instrument. So you need to change your technique and strategy to some degree as to how you're going to instrument the spine or manipulate the spine if you're trying to rely on a static imaging system during the procedure. Sorry. So we tend to use drills rather than awls, and we tend to use monoblock instruments which have less rattling and vibration compared to composite instruments which are put together. And that tends to help reduce the shake. But overall, when we start to look at the studies on this, on the technologies, we can see definitely that robotic and navigated pedicle screw insertions are safer, more accurate than fluoroscopically. And specifically, when looking at the big studies, there are higher odds of accurate placement of implants and lower rates of damage to the facet joints or adjacent tissues or vertebrae, and lower rates of major complications compared to when you do it fluoroscopically. Now, in a scoliosis workflow, it's very often different from most of the published literature because that's done in smaller lumbar degenerate cases and so on. So our workflow has to deal with a big area, and you can't potentially spin on the whole spine. So we'll tend to instrument where we can safely, and then we'll use the imaging system to cross-reference in the more tricky zones, but the spine is more narrow or challenging. As I didn't allude to earlier, it was the one thing we didn't do in that case. And we'll tend to use the navigation both to validate the implants that are in position and to help us guide the ones that are in the most technically challenging position. Okay, so the challenge is it's expensive, and there's often we get pulled into arrangements with companies to use a preferred implant to give you the technology that's there. What we can see overall is that when we look at fluoroscopy versus navigation, navigation comes out on top, apart from where patients are exposed to more radiation. When we look at robotics versus navigation, we can't see any significant statistical advantage. Okay? In virtual reality is the next horizon, and this has just been done, I think, in Dublin for the first time. So Joy Butler shared me this video just to show where we might be heading after when the pub is opening. So we can let the computer and the robot help us to do the rest of it. And will be there much more accurately, much quicker, much safer than previously. Thank you very much.
Thank you, Patrick. Thank you, Patrick, for keeping to time. I'm going to introduce Martin Wilby, a senior neurosurgeon at Walton Neuro Center, does complex work, and he's going to share his thoughts.
Thank you, Mr. Chairman. Thank you, BritSpine organisers. Thank you for inviting me to talk to you today. So a fool with a tool is still a fool, ladies and gentlemen. So some declarations. I'm a full-time spinal neurosurgeon, part of a busy complex spine rota doing a 1 in 12. I'm also the network lead for the Northwest in the regional spinal network. And just to say, as a bit of background, I did an orthopaedic fellowship in Adelaide in 2007, where if you even thought the word navigation, you were rebuked. So yeah, this was very much an old school, old first principles style fellowship. But we have, since 2022 at Liverpool, been using robotic enabling technology, and in particular the Globus robot. So when I speak to the students and the trainees, I often say, when asked a question, try and define the terms that you've been asked about. So here we are, we've been asked about a fool with a tool. So a fool, if you look at the definition, a person who acts unwisely or imprudently, and a tool in this case is robotic spinal surgery. So we've heard from Pat about navigation, and that's, along with robotic surgery, it's part of an example of technology which enables you as a surgeon to do your job better. So this improves patient safety, it improves the accuracy of your construct placement. So we hear more now, we have to get it right first time. This certainly helps you do that. It is also pushing the limit of minimally invasive surgery. So you can do bigger things through smaller incisions, which is better for patients in the long run in terms of wound infection, length of stay, and so on. And the other, obviously with robotic enabling technology, there are a lot of intangible benefits as well, but some of those might include the fact that actually if you're exposing yourself and your staff to a number of x-rays for every pedicle screw, that's probably not a long-term solution for everybody. So to minimize that, this certainly does. You don't take half as many, if any, x-rays whilst you do the procedure. And all of this, these are examples of how we go about improving quality, which is what we should all be striving for. So, as I've mentioned, there are tangible and intangible benefits to robotic surgery. We've already mentioned it improves accuracy, improves safety to you as a user of the kit, but also to your staff. And I was keen to try and follow Pat's talk because I believe robotic surgery is the natural progression from navigated spinal surgery. But what we're still probably trying to work out at Liverpool is really what is the unique selling point of robot compared to navigation. There are some, I think, and I'll try and allude to those later on, but it's really good for minimally invasive surgery, particularly in the lumbar spine. It's also really good for your pelvic screws if you're doing either the iliac bolts or the S2 iliac screws. It's really safe, really quick for that, and it really does speed that process up and makes it much, much safer than trying to orientate yourself to the image intensifier in the theatre suite. And it's also probably really good for upper cervical screw placement, the C1 or the C2, wherever you're starting to dance with the vertebral artery. It's really good at avoiding that, okay? So that's as an overview. However, we need to exercise caution. So if you're training this kit, if you're introducing this kit, we didn't want to exclude users in our department. We wanted to make it open to everyone who has an interest. But how do you then make sure that isn't, it's a safe way of introducing it? How do you make sure you're not applying unsafe principles? You've got to make it equitable for the team. So you don't want to exclude anybody, and anybody who has an interest can play. What's the learning curve? I don't think we know this. We're adapting it. We set some theoretical levels, and I'll come to what we decided upon a little later on. But also, when the kit lets you down, what are you going to do? What are you going to do to get yourself out of jail? when you've got a technical failure. So you have to avoid de-skilling. You have to remember and keep in touch with the anatomical first principles that you were probably trained quite some time ago. And again, how do you maximize training going forwards in the future? Are we going to fully train the new consultants of the future in this technology so that they then can't rely on those first principles? We have to be really clever and careful about what we do for that. So I was asked to just mention some pitfalls that might occur during using a robot. And this one that's encountered, thankfully not that often, but it does happen. It simply won't power up, or there's a problem. The robot won't talk to the X-ray machine. You can't get it to work. You can't progress. Computer says no. So what do you do in that situation? So it's tricky. I think if you've spoken to the patient already and you've, as part of the consent process, mentioned the fact that you are going to use this enabling technology, you may be on a bound to cancel the patient. However, you're more likely going to fall back on your old skills and use the old principles, probably revert to navigation on its own. And as I've said there, you may even consider cancelling the case. We had one patient that refused to have their surgery because if the robot wasn't working. They made that very clear. Pitfall number 2, and this is what we worry about a lot because, as Pat alluded to, you're constantly checking your safety, constantly checking your accuracy. What happens if you lose your accuracy halfway through a case? Well, first of all, how do you know that? With the robot, that's even harder because you don't have the same surface, you don't have the same bony anatomical landmarks to feedback from if you're doing an MAS case. So how would you know? And then how would you be able to finish the case? What would you need to then do to, if you've put 2 screws in, you can't wake the patient up and abandon, you have to then finish the case. You then really do need your old-fashioned skills, your old surgical skills. Often you can just re-image, do another spin, and you can navigate your way out of trouble, but that, thankfully this doesn't happen very much. But industry has gone to great lengths to avoid that problem, ladies and gentlemen. And if you remember the old navigation systems that had a cylindrical dowel that went into the posterior pelvis, that fails in rotation. It's got a very weak rotational dynamic to that. So that's been updated to now the Quattro pin from certain providers. So that's a 4-pointed spike that goes into the pelvis, and that's really stable. That's really solid. That does not rotate. That is not going anywhere, okay? But to give it even more accuracy, sorry, that's if you're doing a percutaneous procedure, you can also open up the spine and use a fixed bony landmark, such as a spinous process, and in that case, you can use a bone clamp. But in order to maintain your assessment of the accuracy of the navigation system that you're using, there is, with certain makes of robot, there is a continuously triangulated 2-point reference system. So you have the important hub of the procedure, the DRB, the dynamic reference space, that holds all of the information of the scan in relation to the patient and real-time camera location basis. And then you have a second point called a surveillance marker, which is a second fixed point, bony point, that is continuously referencing against. And so if you get a discrepancy saying, oh, one's moved, this has changed, it's alerting you that something has potentially changed in your frame setup, and you might then want to reconsider another means of assessing your accuracy. So as I said, the DRB stores the patient registration. Surveillance marker is used to monitor the DRB. Not all systems have this 2-point recognition system. I think this may have been patented by certain tech companies, so not everyone will have it. But this was the basis of why we chose our particular robot, because it had this. There are limits to accuracy as well. So the DRB, as we've mentioned, has only a working level of 5 spinal levels. If you start to transgress beyond that, then you may start to develop inherent accuracy problems. So that means if you put the DRB based on the posterior iliac crest, it gives you a working field up to L1, roughly. So panel number fusions, you're good to go. You don't need a second spin. You don't need to change the position of the dynamic reference base of the frame. Thoracic spine, cervical spine, well, now the stakes are starting to get a bit higher, aren't they? So we're not now just talking about a single nerve root deficit, we're potentially talking about a cord injury. The stakes are that much higher. And in your training for this, the contingency, the stringency is much higher when you are considering doing thoracic versus and cervical cases versus lumbar cases. So for lumbar cases, we are very happy to do fluoromerge, which is taking a preoperative CT scan and then taking 2 X-rays in the theatre with the patient in the position that you're going to operate in, and then merging those. Not only is the robot good in terms of taking you to a fixed point in space, but the navigation system that comes with it is probably improved as well. So the system of merging with the CT is now modular, so that you're actually merging a vertebral body to a vertebral body, not just a scan to an X-ray. So those are quite outdated concepts now. But for the thoracic spine, however, we would recommend that you do an intraoperative CT quality image, such as either a 3D C-arm or a CT equivalent spin, just to maintain that higher level of accuracy, certainly in the neck. And again, to try and address a lot of the issues we've already talked about training, about getting out of trouble, and about the learning curve, for the initial cases, we recommended 2 surgeons going together, and the same for thoracic. I think we still encourage thoracic surgery to be done in tandem, and it's better working with a buddy. Everybody enjoys it more. So very briefly, this is Liverpool's journey to robotic surgery. We began with navigation first in 2009. We used the OARM 1 and 2. Simon Clark led the charge in 2020. Got the idea, we were discussing amongst ourselves to think about this as an option. We had Teams calls. We decided amongst ourselves that the most attractive option was the Globus robot, for reasons I've mentioned. And we only got that in-house after all of the legal framework was worked out in October 2022. We're now 2 years, or more than 2 years down the line. We've done over 175 cases. So I would recommend you have internal governance. Everybody needs to be trained, including your theatre staff. Double it with your buddy for the first 25 cases, which we think is a reasonable estimate of the learning curve. Progress from navigation sequentially, so start with your lumbar cases where the stakes are a little bit lower, and then move on to the more the tiger country later on. So as I said, lumbar for the first 25 cases, and so on and so forth. So in terms of our accuracy, we've put in over 700 pedicle screws. We've had to revise 2 of those. One was an over-optimistic, very narrow pedicle that had an early construct failure, and the other one was just slightly misplaced. They were all within the first 20 cases, so that gives us a revision rate of 0.3%. So that's fairly accurate. So conclusions then, a fool without a tool is still a fool. So you don't need to have a tool to be a fool. If you're a fool, I'm afraid that's a difficult proposition. And there's a separate talk in how we weed out fools in spinal surgery. We have to make sure that we keep our training in hands, freehand techniques. Oh, and I would really recommend, I think there's a lot of literature support that really don't jump straight to navigation, consider using, don't jump straight to robot, go via navigation, because that is a natural progression. Teamwork is key, and did I say before, robot's really good for MAS? I just wanted to show a quick case vignette. This is a 70-year-old guy, 15-year history of left sciatica, an itch that couldn't get scratched. He's had multiple lumbar decompressions, left-sided leg pain, killing his life. He said, oh, I can't go on with this leg pain. That was his scan. You can see he's got a unilateral foraminal shutdown, basically, in the left L4. Yeah, so this chap, that's his standing x-rays. We were converted into orthopedic principles. Put the patient on the table. We took 2 x-rays. Obviously, we put the DRB in the pelvis first and the reference frame in the patient first. Then take 1 AP x-ray, 1 lateral x-ray. It merges to the pre-op CT, and then you're good to go. So then you're live. This picture shows you just how small your incisions can be. So there are 3 pedicle screws going in through those 2-centimeter incisions. Because these screws that we use are modular, we can just apply the screw without the tulip head and then construct the head afterwards. So because of that, the profile of the screw is very, very small. So you can line up your screw trajectories to match, so you can really minimize your incisions. This was an old guy, so I wanted to put these screws in very quickly, then reverted to open, very little time of muscle retraction, very little time of tissue being exposed, did the T-lift, did the decompressions, and this guy was very pleased and went home the next day. So yeah, these are the kind of things you can do. You can expand the repertoire. Finally, we're part of a team. I want to acknowledge my team at Liverpool. Simon Clark is no longer with us. He's gone to Australia. But these are my team, and this is who this data is all based off. So thank you.
Thank you very much for delivering great talks. So I would like to call upon, for discussion, we have another 10 to 15 minutes, and it's a coffee break after that. Please come forward to ask questions. So in terms of my own personal experience in navigation, we've been using navigation in Alder since 2015, 2016, when we moved to the new hospital. I became a consultant in 2016, and I started using, even though I was trained heavily on freehand technique, like I used navigation from the day one of my consultant. And to me, where I can, particularly early onset scoliosis, very dysplastic, NF1, 3-column osteotomies when I'm doing PSO in thoracic spine, hemivertebrectomy to make sure that I've removed all the bone at the nooks and corners. When I'm doing neuromuscular scoliosis, when I'm doing S2I screws. And also, I think key thing is when your navigation kind of shuts down, you need to be able to continue with that case, regardless whether the navigation is working or not working. That is a key thing for me. And it did happen to me, in the middle of a case, neuromuscular, large 130-degree costopelvic impingement, quite severe curve. But that day, the navigation system that I was using, they could not work out even after contacting America. But I continued to do the operation, get on with it. I was able to do, intraoperative. I think the game changer for me is the low-dose intraoperative CT scan, which actually removes your risk of return to theater. I think if you look at literature, Noelle Larson's work, she's done a great work in terms of a low-dose CT scan, intraoperative CT scan, reduces your return to theater quite remarkably. So please, question.
Okay. My name is Jake Timothy. I'm a neurosurgeon from Leeds. And I love navigation. I've used it for 6 years. It's all the things you've said is fantastic. However, it's going to get increase in use. And you do hear stories of it not going quite right. So my question really to the panel, and actually industry, so everything goes well. It's a virtual image on the screen. You think your screws are all perfect, but they're not. Something's gone wrong, and you don't know why. There's been no kind of feedback that it's wrong. Anatomically, you think it's actually okay, but these are all virtual screws. My question really is, who's responsible from a medico-legal point of view? And Martin, actually, it's robotic-assisted surgery, because the robot's not doing it, you're doing the screws. And that's why the companies are very keen to say it's robotic-assisted rather than it's robotic. But that's my question.
So I guess that what we're talking about is the development of unrecognized error during the procedure. And there's the companies have a fairly broad range of an error band that they allow themselves legally, as far as I understand. So they're meant to have, I think, a 3-millimeter error margin, which for any one of us is probably not acceptable from a technical point of view. That's one thing. I think there's a couple of things. One is making it part of your everyday workflow is vital, because then you have a higher chance of picking when the system is a little bit off. Number two, I think make sure that you've got a core team rather than random people trained in it but only occasionally doing it. I think that's another area where teams can fall down because they're not really truly specialized. There's definitely going to be situations where you can have a glitch in the and we've had that with every system where they're telling you it's fine, but you can see that's not. And I'm not sure how you, other than having your eyes open, how you detect it. The question is always also, like, if you've got a problem, do you abandon or do you subject your patient to a second spin? Because particularly in the pediatric community, you're then going to be giving them another massive dose of radiation. So it's a big dilemma for us. Being hyper vigilant and continually rechecking for me is the only way to be sure that you're still staying accurate as the case goes on. But the further you go and the longer the case goes on, the more there will be decay in the quality of your precision, of your accuracy.
I would like just to know from the audience, could you please raise your hand if you're doing a procedure, if you think that if the navigation wasn't working, would you cancel the case or would you close up in any unit? Would you do that? Sorry, yeah. Please stay.
I'm just going to respond to Pat. I've known Pat for a long time. He's got the great gift of the gab. You are Irish, but you haven't answered the question, Pat. The question is, who takes responsibility? You've done all the things, you're very experienced, you've checked everything looks absolutely fine, you put the screw in, it's in a nerve root. When you actually take the final spin, you go, oh shit, it's in a nerve root.
Sure,
But if the patient has an adverse response,
so
is responsible?
We had a case like this, but what had happened was that the reference ball on the array had not been put on fully tight. It was 2 millimeters off, and that was not recognized. No, there was no long-term sequelae, but the institution would have taken because it was the team, not the surgeon who puts the little fiddly balls on the arrays, but the team would have, and the institution would have taken the liability for that situation had there been an event. If this is definitely an infrastructure technology fault, then I think it's the provider of the technology, I guess. That may be answering your question well enough.
I think still these are surgical urgents. I think it's still surgeon is responsible. For everything that goes on in theatre, I think there's no doubt whether you use the technology or don't use the technology. I think it's the surgeon's responsibility, in my opinion. I hope most people in this room agree with that. Next question, please.
Hi, my name is Aisha Ashad. I'm the senior spine fellow. I'm working in pediatric deformity at Oxford University Hospital. We started using robot for pediatric deformity surgeries about a couple of years back. And we have recently done a project to compare the robot-assisted versus the conventional freehand technology in pediatric deformity surgery. We are presenting a poster about this as well, in which we compare the two groups. And me being on the student side and trying to understand all of this, as well as more than keen to embrace all the emerging new technologies, being at my stage, it was very interesting for me to find out that we went through a learning experience and we actually improved in our operative time and our blood loss. And actually in our later cases, it became comparable to the conventional freehand technique. By the end of 2 years, we were doing surgeries with operative time and blood loss comparative to what we achieved in conventional freehand technique. One thing we could not achieve was the radiation dose, which was, of course, much higher in the robot-assisted, and, of course, the accuracy. So these two things are already established, but it was very interesting to see that. And I would like you, both of you, to share your experiences if you have had a look at these things and if you have had similar experiences. Because personally, as a student, and at my stage, I feel that any emerging technology should be given a chance and should be embraced, but it will prove its mettle only if it is compared against the index standard, which is conventional freehand for pediatric deformity surgery.
Yes. Yeah, thank you. Great question. So there's quite a bit of literature emerging on this that suggests that the biggest step up is going from navigation So from freehand to navigation, and then the gap between navigation to robot is not as big. So people who go into doing robotic surgery who've already got that navigation experience have a very shorter learning period. And I think, you know, they said it was 31 cases for someone who hadn't ever used navigation before. But so I'd be interested to ask you, did you use navigation before without robot before, or did you go into it completely new?
So our comparison arms were just conventional freehand versus robot assisted, and that robot was introduced with, so we did not use navigation for pediatric deformity, we just introduced robot navigation. But actually we found that almost all of our surgeons, by their 7th surgery, the operative time was equal to the conventional freehand, which was a big thing to find out. It was just 7 surgeries for every surgeon. And then even in blood loss also, it took about 8 to 10 surgeries for each surgeon. So it's a learning experience as a team. It's not just one surgeon. So we did find out that up to almost 10 or 12 surgeries, the surgeons were performing at the same level, although they were doing conventional freehand for a far, far longer time than they were doing robot-assisted. So that is definitely a strong point for robot-assisted surgery. But at the same time, we have to consider that the radiation dose is still much higher, especially in pediatric population. That becomes very important. So we have to consider all these pros and cons.
Exactly.
At least that's what our take is from our project so far. It is not a very extensive project. It's just 2 years.
I think the point is, as you said, your surgeons moved from freehand to robotics. It would have been different if they moved from a freehand to navigation to robotic, because if you're a prolific user of a freehand and a navigation, currently in the pediatric literature, pediatric spine surgery, deformity surgery, there's a very little add-on for the robotics, from navigation.
There's maybe more of a subtraction than an add-on in ways because of the logistics.
Exactly. Yeah. But I think the game changer will be when the robotics start to do your 3-column osteotomy with very less risk of dural tear or, cord injury, like how urologists are using the robotics as to, their soft tissue handling is much better with the robotics. Then it's a game changer. And if you're not using the robotics now, I think down the line, you adopting it is going to be quite difficult.
Yes, and I personally think from my take from that project, for pediatrics, the game changer would be the radiation dose.
Yes.
Once they have a software which decreases the radiation dose, because for pediatrics, every CT scan counts, every spin counts.
So that's all already been dealt with because there are already MRI-based imagings.
That is, I think, once that is more freely available or more freely,
It'll be soon. It'll be very soon.
I think there's one way to speed up the learning curve, and that's to use it in every case, especially the cases you don't need it, because then you get a feel for how it's working and how accurate it is within the operating theatre and with your team. I think that makes a massive difference. In the freehand group, did any of them, of the surgeons, use imaging like fluoroscopy to confirm their implant positions, or did they just go, it's perfect, I know. I have the navigation chip in my brain.
They did what all the scoliosis surgeons do all over the world. So they did confirm at the end of surgery that the screws are fine.
Great. Alex,
Alex Gibson, Stanmore, thank you very much for great session, presentation, all of you. I'm a freehand surgeon, and I was trained that way. But when Sean Malloy at our centre started to develop navigation stuff, I let him do it. And I didn't try and do it. He was the only one really, or the major one who was pushing it. And he did exactly what you said, Pat, which is use it for every single case, because not only has he got to get used to how it works, but he's got to train the team around him. So, and you've got to know every time Sean's got a list, everybody knows, right, it's OARM for every case.
Yeah.
So no question, everybody just got used to that now. Initially there was sort of eye rolling and all this sort of stuff. Oh, it's going to take forever. But now it's just like routine, bang, 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 bang. And I didn't do anything. And then, because I was already a consultant before Nav came in, I started operating with Sean. We did some joint cases together, and we would do it always his way. So then, over the course of the last, I would say, 10 years, I've effectively done a fellowship over that period with him of navigated surgery, and that has stood me in great stead. So I can really recommend that way of learning navigation if you're not an innovator and an early adopter. I am definitely a laggard. I know that I am. I'm proud to be one. But I recognise that navigation is really useful in certain situations. Not for 90% of my cases. I can do 90% of my cases freehand, no problem. But if I've got a really difficult revision, scoliosis, multiply operated, no landmarks, I'm guessing, and that's not good. I should be using navigation. When you're doing freehand, when you're doing navigation open surgery, scoliosis, which is majority of my work, I would say robotics is of minimal added benefit. I would say the current generation of robot that Globus and everybody else has got is almost as good as my left hand holding the drill, but not quite. Yeah? The urology robotics stuff, which you mentioned, is very different. They're sitting in a corner of the room, and they're operating down a track which you wouldn't be able to get your hands and your instruments down in, but the robot can. And they're manipulating with little machine in the corner, and that's brilliant for them. And for some of the complex stuff, like complex 3-column osteotomies, like you mentioned, that could work, and that could be a real advantage. And for MIS, though, I suspect, I don't do MIS, but I suspect a robotic drill guide is great for that.
I mean, that's the thing. I've come from navigation to do MAS, but I now completely trust the navigation with the robot that I didn't before. I didn't really feel safe doing it. Now I feel safe. Yeah. I've got used to the little quirks and the noises the robot makes, and I can tell when it's not happy, and I listen to it, and then we get by.
Just to come back to what was said earlier about when you get it, when is the navigation wrong? I think it's really hard to know that it's wrong when you're doing MIS. And there are some registration problems. So sometimes there's a computer glitch, a software problem, or a hardware issue that puts your navigating probe, you think it's in the right place, completely wrong. And it's very rare, but it happens from time to time. And the company will always say, it's not possible that it's our machine. It's the surgeon's error. But I'm sure that's not the case all the time. So some of the cases, I'm sure it is. But there is... So for open surgery, it's easy. If it don't look right, it's not right. Yeah. Okay? It doesn't matter what the bloody screen says. Yeah. I wouldn't put a screw in that position normally. There's something wrong I need to check. Yeah. MIS, much more difficult, I suspect.
Yeah, absolutely.
Good comment, Alex. The other thing is, I think we, as a society, we should not head towards like how general surgeons have become now. Only few general surgeons can do open cholecystectomy. Like, you know, they're so ingrained into doing lap chole that if they have a bile duct injury, most of the patients are being sent to, or closed up and being sent to a hepatobiliary unit. As a surgeons, like we shouldn't, and as a spinal surgeon, I don't think so. We should be in that position.
There's another point to that though, and that's that all of the trainees who are going on fellowship training across the world are in institutions in North America, Australia, wherever, and they're learning with new technologies. It's part of their staple. So they all are on the iPhone 16, you know. They're not going to settle for a iPhone 1, and that's how they function. And you won't be able to track them to your unit and keep them if they don't have the assisted technologies that they've developed with. That's definitely going to be a recruitment thing in the future. I think we have to acknowledge that fact. The second thing is certainly you need support from industry, because as the technologies get more advanced, you need the support, you need the awareness. So it's not good enough to have done a one weekend training course and say I'm equipped with the knowledge to solve any glitches, and it really is building the experience to know when there are glitches is vital. Yeah.
Thank you. Rajat, please.
Right. Hi, Rajat Verma. I work in Manchester. My declaration of interest is that I mainly use freehand. The question really is, do any of you who use navigation robotics or any other technology, do you consent patients that you'll break down, and what you will do? Because I have started consenting patients for breakdown of the neuromonitoring stuff. And I have had where the fuse is blown and we've only got one neuromonitoring machine in the hospital, and I've abandoned. But there are some children with special needs where I have a conversation with the parents that, you know, if the monitoring doesn't work out, then either we carry on, and if the child has got not much to lose from a neurological function point of view, then we just carry on. But I think the same consent conversation needs to be had for any technology that you're using in theatre.
I think the safety net analogy is very good. So we always talk about the safety net, the elements to the safety net, and that it should be there through the operation, but that there are some kids who we may not have the same level of a safety net because they may not, from a monitoring point of view or a technology point of view, it may not be as reliable. But we do, in our hospital, as a result of an injury that occurred, we do call the family if there's a change from the plan. And if they're happy to proceed, then we explain the further plan if there's a situation with monitoring or any other situation. Of course, you personally have to be happy to, or as a team, you need to be happy to proceed further. It depends on the scenario, but I think it's reasonable to kind of work that out and plot that way.
Yeah, thanks. I think pre-op discussion probably is better than, that's definitely something that needs to be incorporated in consent. Thanks.
Thank you. Next. Rex.
Hi, Rex. I don't know how many of you know me. Trained in Belfast, fellowship in Leeds, worked in Sheffield, now in Dubai. And I've been through the whole thing. Freehand, no x-rays, all screws put in with x-rays. With the colleagues here, and then now all screws put in with navigation. And currently working in a hospital where we have robotics. The main reason I came here is to say, no conflict of interest, I personally do not think robotics adds anything to navigation. It delays things. There's a potential for misplacement of screws. There's a potential for a huge amount of harm that can be done. Because the feel you get from the drill is not what you get from navigation and your own hands. So that's my conflict of interest. I don't know what you feel. I mean, obviously, everybody who uses robotics says it's amazing and it's better for your shoulders because you don't push down and, when you get older, your shoulders are protected.
Thanks. I mean, I agree with part of what you say, and I think we've already alluded to the previous question that for the thoracic spine, I don't know what robotics adds more than navigation when you're doing a thoracic instrumentation. But for MIS, for upper cervical, disagree. Sorry.
Thank you for your talks. It was really interesting. My name's Nish. I'm a consultant in Liverpool, and I'm early doors. I'm 2 years into it. And essentially, I have a big concern, which I think is shared by a lot of spine surgeons in the room. And I think that we may be handicapping our younger generation of spine surgeons by using navigation and robot, because essentially, you guys are senior, and you've gone through the heydays of doing everything freehand, and then you're moving with that knowledge over to using nav. I was lucky enough, like you, Martin, to do a fellowship in North America, and we use freehand and x-rays, so I got all of my knowledge from that. But you're basically having a whole generation where your work streams are nav and robotic, and then you keep on saying, then you go back to anatomical principles. There's a whole generation who are not learning anatomical principles. So how do we address that as a group?
I think you can merge it in my practice anyway, because we start freehand and it takes nothing to put the checking probe on the track to confirm that you're where you thought you were. It takes nothing to do that. So it's reinforcing. So if you've got different sources of information to ensure accuracy, you've got your haptic skills, which may be the greatest tool of the lot, yeah? But you've also got a visual from the navigation, and you've also got an electrical impedance test of the screw track to say you're not near the cord. You're improving your accuracy or precision all the time. So I think you don't have to lose one to adopt another. But I'm talking in a discussion with a German surgeon about this. The fellows and residents are not allowed to use navigation or robotics until they know how to do it open. So that's the other way they do it, and that's another way to safeguard. But the only thing I really learned from navigation, and this is how much more you see and how much more you appreciate what's under the surface, and the amount of times you go, I was going to go for that, but thank God I actually just my instincts were not to push for that one. And when you see it in 3D, you go, maybe a screw there was not such a good idea. So it's as important to visualize what not to do as to going with the original plan, for me anyway, personally.
So Nish, the point to add here is like, I would not change my technique if I'm using my freehand or navigation. I will use the navigation pointer to see. But also what it gives you is like, if you're using, out in technique, sometimes you feel like, the feeling, the haptics that you develop with the navigation is that when you're not using the navigation, you can still feel that, and you can actually confidently say that this is out in, or this is, medial breach. You should be able to feel freehand. You should be able to feel that, navigate. But I don't necessarily use the screwdriver, navigate every screwdriver, nothing. I just use the point. I still feel every single pilot hole that I made through the navigation, I still feel, because I still, freehand is the best in terms of your haptics.
So that's comforting to know, because basically I use the nav, start point check, and then basically freehand, and the next row at the end, and that's what I think is
that's
the
the
best
best
workflow.
way. That's the best way.
I think we're quite over time, so I think...
Can I make a philosophical little thing to end on? This isn't really a question. I'm Stuart Blagg from Stoke Mandeville, and I've been using a robot for a year. It's been quite interesting. If you look at our robots, they're the first stage. They're really an assistant, which helps us a bit. But if you look at the Leonardo, if you look at what the urologists, the general surgeons are doing, these things are doing whole operations. But look at it the other way around. What's actually going on? The amount of data at the end of your case that's sent back to the companies is thousands of times more than comes down the line. Every single case, that general surgeon, that urologist is teaching that robot. Now, at some point, that robot doesn't need the general surgeon anymore. So what we're actually doing is teaching a very, very good junior who's going to put all of us out of work at some stage.
Thank you.
I look forward to
the last question.
But I think we as a spinal surgeon, I was in SRS or something, like we are probably more than 30 years, behind that.
We're not teaching the robots, but the general surgeons are.
They are.
Sorry, just like, my name is Donald O'Donoghue. I used to be a spinal surgeon in Liverpool, and we actually bought, we were the first to buy a spinal navigation system in 2005. Everybody else who'd had it before us was on free trial. But one of my fondest memories, because the point has been made about training, one of my fondest memories was the stress of watching a trainee doing their first pedicle screws, and that put my heart rate up to 100, 180. Navigation was an absolute godsend. So my trainees were allowed to put screws in way earlier in their career because I knew exactly where the probe was pointing. And one of the ways of training, and I think there's a couple of my victims are in the audience today. What I used to do is insist that they show me where they're going to put it as if it were freehand, and only then look at the screen to see where they were navigating. So as a training tool, it enhanced the training rather than subtracting from it. And the last thing, Pat, I'm really delighted to hear you saying this, was you have to use it in every single case, all the routine stuff. The reason it was sat in the corridor was people were only using it for big ticket cases. So they... Thank you.
I think we need to get this to a close.
Yes, I think thank you very much for all the discussion and viewpoints. Thank you. Really appreciate this. Has been successful.